Now, I want to talk about surveillance, and this is a topic I particularly like. It's not that I don't like the rest of them. I like everything I teach related to epidemiology because it's so interesting. But surveillance is really keeping track of data and looking at trends. And so I'll read to you about that here pretty soon. But these are the topics that I want to cover about surveillance. I want to give you a definition, and then I want to talk to you about one of the types of surveillance that we use because it has to do with collecting information and collecting data. And we'll talk about the purpose, the definition, the level, the criteria, when to screen, and when not to, and I should say, and when to and when not to screen, and sensitivity and specificity. We'll define these terms. I'm going to give you a whole bunch of terms that have formulas with them. So as you go through, you can just see what it is that we're going to cover. This is another intense area, but I think you'll find it interesting, and this is information you should request and know about in terms of a screening test, and there are all kinds of them, and I will ask you about them and ask you to generate a list. So let's focus a minute on surveillance. And I said, as I mentioned, it's keeping track over time of morbidity, mortality, injury, and disability. That's really what surveillance is. Some people think about it as a cop car sitting outside their home, waiting for them to arrive because they've been involved in some illegal activity. Well, I'm joking about that, obviously, but that's not what we mean by surveillance here. It's data driven. The purpose is to detect changes in diseases and to initiate appropriate prevention, control, and protection measures. That's why we're keeping track. And we've covered that throughout the entirety of the course and in the definition that we've used and of epidemiology. So I think you should be pretty well grounded by this point as to really what the purpose of epidemiology is all about. And what we want to do is we want to systematically collect data. We don't want it to be done in a shoddy way. And we're going to talk about problems with collecting data. And even though we have these problems, what should we do? Is the data all no good or unusable, or should we throw it out, or should we just guess, or what approach would you take? So we collect it. We collate it. We have analyses in the timely dissemination of information to those who need to know so that action can be taken. The CDC is one of those agencies that keeps track of trends over time, as you well know. And they often publish information in the MMWR, or the Morbidity and Mortality Weekly Report. And I would suggest that you sign up for that. You can go online and get that publication, and it'll just provide you with a whole lot of information that might be useful to you in whatever occupation that you're in or you're aspiring to be in. I want to give some surveillance examples. So we have, as I mentioned, we have systematic collections and evaluation of morbidity and mortality rates. We talked about the MMWR. We have special reports from field investigations of pandemics, epidemics, and individual cases or outbreaks. So some of the data that we are showing you comes from the MMWR, especially as it has to do with these terms that we've introduced. And how can we isolate and identify infectious agents? That's another important consideration and factor that's so important to us in terms of what will happen if a disease gets out of control and we don't have either the medical treatment available the or the right vaccines or whatnot. So we're also concerned about the availability, use, and effects of vaccines, toxins, insecticides, and other substance used in prevention and control. And a lot of times we don't think about insecticides, but an abatement program is often a very important consideration for a city. I know the city that I lived in had a mosquito problem, so they had a mosquito abatement team that rode around in a Jeep, or if you have a military background, in a quarter-ton truck, and sprayed all the drains. And they sprayed them with a particular poison to keep the number of mosquitoes intact because they didn't want to have problems. Um, we also look at immunity levels in segments of the population, and I think this is extremely interesting. We want to know whether people can resist a disease and something like anthrax or anything of that nature. Do they have the ability to ward off diseases is really what we're interested in there. So you can see that a lot is done under the area of surveillance. And now screening is a special type of surveillance. It's a data collection method, and we'll spend quite a bit of time on screening because I think it's important for you to know. It's important for you to know for yourself, for your family, if you're working with a patient population, if you're working with the public, whatever means or whatever you're doing, knowing about screening and knowing how to evaluate a screening test is very critical to you. Now, it says, and let's just look at this together. It's the presumptive, and what we mean by presumptive, a belief supported by probability, identification of an unrecognized disease or defect by the applications of tests, examinations, or other procedures which can be applied rapidly to sort out apparently ill and well persons from those who probably have the disease and those who do not. Okay, so we're looking at those who are diseased and we're trying to compare or isolate or put into categories those who probably do not have the disease. So we look at disease and non-disease. And screening is one method of surveillance, and this is very important that you know. A screening test is not a diagnosis. It's a data point, and a collection of data points done by different screening procedures with the help of a trained professional lead us to a diagnosis based on certain criteria that usually have been agreed upon by a group of professionals and are published and available. Now, the Diagnostic and Statistical Manual of Mental Disorders, which is changing. We're going to number 5 now. It is agreed upon criteria to help us in determining a diagnosis for a certain problem. Now, let's talk about examples of screening tests. They can be done in any number of ways. They can be done as a survey. They can be done through social media. They could be done through interviews. They could be done through focus groups. And then we have all kinds of medical screening tests, and I'm going to get you started here, and I want you to think right along with me because the top ones I thought you probably wouldn't get on your own, but you use screening tests. Many of you use screening tests or get the results from screening tests all the time. That's through a thermometer, blood pressure, blood glucose, body weight, pulse, pregnancy test, um, monitoring of evaluation cycle, mammogram, sonogram, imagery, etc. So we have all kinds of routine screening tests. They're not a diagnosis, they're just a data point, and the collection of that information helps us to determine whether or not you meet the criteria for a certain diagnosis. The Control of Communicable Diseases Manual, which you've heard me refer to over and over and over again, gives you those criteria. So you can look in the manual to determine whether somebody meets the criteria for a certain disease or not. So, um, and some screening tests, as we mentioned, are OTC, over-the-counter products. And those, for example, we talked about one of them, which was a pregnancy test. And we have others that are sold and that you can purchase. And sometimes you'll use a blood pressure cuff and when you go to the pharmacy and you'll take your own blood pressure, and in that case you're doing your own self-screening to see whether your blood pressure is in the appropriate range or not. Now, this is an example that has to do with cost and contact with people and what happens in terms of the number of professionals being used. Now, when we do this, if we in phase one, if we administer a short screening test, that's not going to cost us very much. That's going to be very quick. Okay, and if this screening test indicates a particular problem, then oftentimes we can go ahead and conduct a diagnostic interview, and this is going to cost us a lot of money. So the screening test data, along with the interview and the criteria and the methods of deciding as to whether or not somebody has a certain disease and is diagnosed with that disease, is an expensive process. So this tells us whether we need to go on to the next phase or the interview of interviewing somebody or not. Phase three, we can do all kinds of other tests: biological, medical, physiological, behavioral, mental, psychological, etc. And this becomes a very costly and expensive process as well. And when we look at afterwards, might be the time that we would administer a research questionnaire to look at those who have been diagnosed and look at the factors that go along with that diagnosis to see whether or not we can predict who might develop a particular disease or not. So we're into prevention, protection, and control again. Okay, now you know that with screening tests we have normal limits or cutoff points, and usually we have points where we consider somebody positive or potentially has a problem, and they're often dichotomous. They're split into two categories, either yes or no. Now, notice with blood pressure, if you have a systolic blood pressure above 140 or a diastolic blood pressure above 90, either one of those, you might be you would be considered hypertensive. And what are some of the other examples? Um, Now, I was talking about changing the cutoff point. I don't want to leave that quite yet. We could drop that to 130 over 80, and that would probably be more appropriate for some of the college populations. Um, we have tests for diabetes and chronic kidney disease and whatnot. And so we might look at glucose tolerance, and there's just a whole list of things where we begin to screen. And so I'm just asking you to open your imagination up and think about all those various things that you've been exposed to in terms of screening. Mike,
Yeah.
so we're going to have to start. Okay.
I'll just make a note of where the pause is.
Okay.
Yeah.
The next thing I want to focus on is what screening tests were developed for or designed for. And they're very much a population based method. And so when we think of screening tests, they're for large populations. They're innocuous, they don't hurt, or they're non intrusive. These are the best ones. People don't like to be poked with a needle if they can avoid it. Some are phobic, etc. Um, we want them to be safe. We want them, especially to follow Occam's razor, we want them to be brief, and I'm saying again parsimonious, but brief, simple, and and the purpose may be ambiguous to reduce response bias. We don't. Sometimes we just don't want to give away what it is that we're trying to collect information about. Inexpensive. They would We would want them carried out by somebody who is trained and knowledgeable and familiar with the test. You don't want somebody to take your blood pressure that doesn't know how and doesn't know how to listen correctly to the beating of the heart. Um, we would like them to have face validity, and by that we mean that they're acceptable to the people being screened. They make sense to them. It makes sense that this does is used for a certain function. And of course, we look at reliability and the validity of the test. And some tests are more valid and reliable than others, and we'll talk about that later on. So, what we're interested in something that's quick, easy to use, and they're not painful, and we've given all those examples before. Okay, the criteria for disease selection is as to when to screen. Um, the 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 condition should be an important health issue. We don't want to be screening for something that's not important or only is it's rare, it doesn't occur very often or whatnot, because that adds to the expense, and we're going to have to screen a lot of people before we find anybody who tests positive. Now, with a screening test, you should be able to differentiate diseased individuals from non-diseased individuals through diagnostic tests used after the administration of the screening test. But what helps to establish the reliability and validity of these tests is how the screening test performs in relationship to the diagnostic or gold standard test. Uh, Prognosis should be improved if the disease is detected and treated early. This has always been a big debate. If you have no treatment for somebody, should you be screening for a particular disease? Some would say yes, some would say no. Some would say ignorance is bliss. Others would like to know the information so they can do planning and make other changes. Okay, there should be a recognizable symptomatic stage, incubation period. This gives you the idea so that we can intervene early, so that a person doesn't have to go through the entire stages of the disease, as I've shown you in other graphics earlier. So if we can prevent and control early or offer an intervention, this is always desirable. And we talked about that there should be an acceptable treatment for patients. And we don't want to just identify them and not be able to do something for them. Um, um, Sometimes that's not always possible, but that's the goal, and that's the goal, especially of using a screening test. We want a problem that's prevalent. We don't want one that's again that is rare, that doesn't occur very often. And we want to have adequate facilities for diagnosis and treatment. If we happen to find a number of people who test positive and have been diagnosed in a positive fashion, but again, we want to have enough facilities and professionals, I should say, right in here for diagnosis and treatment. If we were looking at athletes and eating disorders, and there's screening tests for that, we would want to make certain that whatever treatment facilities were available, that we had adequate people for diagnosis and treatment. Otherwise, and I'm certain if we had a careful screening, many of these facilities might become overwhelmed. And we're worried about that in terms of a pandemic. If we had a wide-scale problem, would we have enough medical supplies and personnel to really be available for diagnosis and treatment? When not to screen? Well, when you can't make the diagnosis with certainty. Again, why bother? You don't want to do it when data are unavailable to demonstrate if early treatment is more effective than later treatment. Most of the good results are from treating participants who do not require treatment, and we often find this. A good example is if you have an exercise study, usually you find that those who enroll in the study are those who exercise. And so then we think a treatment is really good and effective because the people who are already engaging in the behavior and are superior to others are involved in the intervention. So you get a false sense of security. When the efficacy or the effectiveness of the treatment is doubtful or it's not been demonstrated, and this slide says through randomized controlled trials. Well, in medicine we believe these are the best trials, but our attitudes and are changing about the utilization of other types of designs that provide a lot of important information. And one of the things I'll be talking to you is about research designs, and you'll know those as well as you know about screening or any other topic that we've covered. We said if the disease is rare, because you don't want to screen, because you have to go through so many people to find one positive case. If you have to do something harmful to somebody in order to determine whether or not they have the disease or to make a diagnosis, and you can't be certain of whether it's an effective means of making the diagnosis, that doubly compounds the problem. When the results of the screening test are unstable or aren't repeatable, so you have no reliability. One time you get one result, one time you get another result. We have this happen with blood pressure because it's very labile. It goes up and down, and we have the white coat phenomena, as many of you are aware of. And as soon as somebody comes into a medical office, their blood pressure jumps up immeasurably. I mean, I guess I should say measurably, because people are just panicked or frightened or have a reaction to the fact that somebody in a doctor's office or a physician's office is going to take their blood pressure. Okay, so I'm going to talk to you about these in a minute, about the two terms sensitivity and specificity. And if a test is not very well constructed, it doesn't do a very good job of screening, you don't want to use it. You're going to get too many errors in classification. Another reason, the mass screening, diagnosis, and treatment may cost more money than the initial treatment. So if you're going to spend millions of dollars doing a screening rather than evaluating those people who go through the medical process naturally and receive the treatment as they seemingly need it, that might be a far more effective way. So you wouldn't want to spend millions if it's not needed. Okay, I want to talk about sensitivity, and this is an important term, and one we're going to talk about calculations that you're going to learn for each one of these, and I'll give you a homework assignment in regards to this, and there should be homework assignments available. Now, when we talk about sensitivity, we're looking at the proportion of truly diseased persons who are classified as true positives or potentially have the disease, and this classification is done by the screening test. So that's what we would hope that the test would do two things. It would agree with the gold standard of diagnosis, that those people that have the disease really do, and those people who don't have the disease really don't. But sensitivity measures the probability of correctly identifying a case with the disease, and this is done by the screening test. Okay, so that's an important thing to remember. Now, specificity is a proportion of truly non-diseased persons based on the true status who are correctly identified by the screening test as not having the disease. So we're wanting that screening test to identify those who truly have the disease and those who truly do not have the disease. And if we could get that to happen, we would just have two dichotomous categories of diseased and not diseased. Very rarely does that happen. Now, and I've talked about this, and I think you're beginning to get the idea of what a screening test does and when to use it and what we're seeking from it. Now, predictive values. We have positive predictive value and we have a negative predictive value. And this is a probability that the test, the screening test, is positive when all positive tests are taken into account. Okay, so that means that it has true positives and false positives. And when those are taken into account, we have a certain positive predictive value in terms of classification and how well the test identifies those who are positive. The same thing is true with negative predictive value. We have true negatives and we have false negatives. And this means that we want to be able to identify true negatives and what is the relationship between that and false negatives. And so we get a value from that, and I'll talk about that more and you'll see the test results as we go along. Okay, this is a typical screening test layout. you notice at the top we have, this is true status, okay? And you can see how it's determined. And we have disease and not disease, and we have a total. And these are screening test results, positive, negative, and total. So we have true positives, false negatives, and true negatives. Okay? Now, the nomenclature that we usually prefer is A, B, C, and D. And the formulas that I'm going to show you will use A, B, C, and D. If you wanted to, and I don't care, it doesn't make any difference to me, you can use true positive, false negative, or true negative. That would be fine too. As long as you come up with the right answer, who cares? Okay? And positive predictive value had to do with these two test results, and negative predictive value had to do with these two test results. And specificity, sensitivity has to do with these two test results, and specificity has to do with these two test results. And I'll talk about those more in detail. But when we're talking about positive predictive value and negative predictive value, we're doing row work. Okay? So we're doing row work across. When we're dealing with sensitivity and specificity, we're doing column work. Okay? On to the next, and here are the formulas that we're going to begin, you're going to begin to learn, and because we obviously are dealing with a proportion, right? And the reason we're dealing with the proportion in each one of these cases is because what is in the numerator is repeated in the denominator. So you can see in each case how they're set up, right? So you can see that in the denominator, whatever in the numerator is repeated, and we multiply each by 100%. So that's the constant. Okay, so if we're talking about positive predictive value, let's start over here. So we're going to have A divided by A plus B. Negative predictive value, we're going to, and this is where people often have problems, it's going to be D, because we're interested in true negatives. In the first positive predictive value, we were interested in true positives. So you're going to have D divided by D plus C. Okay? And that's the row work that we're going to do immediately. Now let's talk about the column work. In sensitivity is A over A plus C times 100%, and specificity is D over D plus B. Now, the most important terms that you're going to learn and that you want to know about and speak to the quality of the test are sensitivity and specificity. These are reported in the research literature, and they're reported for every one of the screening tests you use in a physician's office, and many others that are available for research and other purposes. And these two are important to take into account and to be knowledgeable about. Okay. Now, I want to talk about calculating false positives. Let me go back and show you what a false positive is. A false positive is a person that tests positive but does so falsely. Okay? So really, they're non-diseased. Now, let's look at what we're talking about. We're going to talk about, there's two traditional methods there, and I'm going to show you another method of calculating false positives and false negatives. So when we look at the traditional method, it has to do with column work. And if you go back and look at the table, then we're going to be essentially what we're doing is focusing on every cell. We're going to go back up here and we're going to look at B over B plus D. We would reverse it to make it a proportion times 100%. Okay, if we're going to look at a false negative and it's column work, it's going to be C over C plus A times 100%. So those are the formulas, and that's how they're calculated, and you can see it here, and you can become familiar with it. So that's column work that we've done in that instance. And a good test for yourself is, as we go along, is to write all the formulas down, and I'll talk to you about how to abbreviate them so you know the proper abbreviation. I'll show you that, and then you write the formulas down, then you do the calculations, and then you have another um, um, column where you can talk about whether it's column or row work, or or just what type of work you're doing in order to do the calculations so you're familiar with the process. Okay, other ways to calculate false positives and false negatives. Now, we calculated those traditional values based on the gold standard, and now we're going to for the gold standard, I should say. I hope that doesn't confuse you. And now we're going to calculate them for the test itself. Okay, so we're going to calculate them this way, and we're going to do row work instead of column work. Okay, so let's go to that, and you'll see very quickly. And we know that false positives are in the B box, and so you'd have B divided by B plus A times 100%. And what are those? The proportion of those, again, who tested negative, who were false negatives, and we would look at C divided by C plus D times 100%. So we can calculate false positives and false negatives in two ways. The traditional way is by column work, and the less often seen method but still used is row work. Now, what the cells mean. Most of you have had statistics, and you always hear these terms thrown about and probably have never really particularly understood them. They talk about what a type 1 error is and what a type 2 error is. Well, when we talk about a type 1 error, we're talking about a false positive, and hopefully this will help you never to forget what these terms mean. So a false positive really means somebody doesn't have a disease or they're negative for it. Okay, a type 2 error is a false negative. That means they tested negative, but they really have the disease. And these people cause us a whole lot of problems. You can think of Typhoid Mary, somebody who went undetected. She tested negative. She was a false negative, and she was really positive for the disease. Now I want to talk to you about another type of error, which is a type 3 error. And this is an intervention implementation error. All that means is a poorly designed and implemented intervention. So somebody has constructed an intervention to treat obesity or a treatment for any particular disease or disorder, but it's been ill-conceived, it hasn't been designed well, and the people who are using it or operating it don't know what they're doing. That's a type 3 error. And unfortunately, we see a lot of type 3 errors that occur in the research literature. And often they're hard to detect because people don't tell about their interventions. But if you've had exposure to interventions and trying to help people, you have witnessed practices that are not best practices at all. Okay. Now, here's an opportunity for you to practice your skills and for you to see how all of this is abbreviated. What we're going to do is sensitivity and specificity. And you know that if we were going to do sensitivity, what I would ask you to do, even though we haven't done it here, I would ask you to write down the formulas and plug in the numbers and come up with the answer. And then we need some interpretation. Okay? So, and I'll go back to that again here in a minute. So we're going to go A over A plus C times 100%. In this case, with these values equals 80. Specificity, and this is how they're abbreviated, specificity of the test, we're going to go 800. Now here's where people usually make mistakes. They don't take the true negatives. What they do is they take the false positives. Because they took this value to arrive at sensitivity, they want to take this value to arrive at specificity. That's wrong. You're going to come out with the wrong answer. And real easy to do. And I want you to avoid that problem. So we're going to take D over D plus B times 100%, and the specificity is 89%. Now, this is how we get validity. Once you get the sensitivity and specificity, you're going to add those two together and subtract them from 100. Okay? Now, this would tell you, if I was going to provide an interpretation of that data, that 8 out of 10, or 80% of the people who took the test, who tested positive, were positive. 89% of the people who took the test and were negative tested negative. Okay? And so if we could have an ideal test, all of the people who were true positives and true negatives would fall into these two cells. Okay. There's validity. Does a test measure what it's supposed to measure? There's the formula. And if we plugged it in, we come up with this value. And so if we were going to, now I'm writing out an interpretation for you, because I said the other quickly and you might not have got it, although you can replay it. This says 69% of the time the test will identify true positives and true negatives correctly. Or if you want to make it into, you want to communicate it in another way, you'd say 7 out of 10 times that's what's going to occur. So 7 out of 10 who are true positives and true negatives, the test is going to be able to identify them. Okay? The next question for you are, what two measures assess validity? And that's sensitivity and specificity. The next has to do is, what are the two most important measures of a screening test? And you'll know that right away. You'll say sensitivity and specificity, and they both take into account true positives and negatives. So very important, yes, and this is the information that's reported in the literature, and this is the information that you want to understand and be able to report. Okay? I have a couple of other statistics pertaining to screening tests that I would like to introduce to you, and you can see that we have used all rows and all columns, and now we're going to do some diagonal work. And I want to introduce the concept of yield to you because it really has to do philosophically with what a screening test is supposed to do. Is it supposed to identify those who are true positives, or is it supposed to identify those who are true negatives, or is it supposed to do an equal job of doing both, identifying true positives and true negatives? But philosophically, when screening tests were first developed, the point was that the test, if it was a good one, was to identify true positives. And if it didn't do anything else, if it would just identify true positives, and all of those people who were true positives were in cell A, then the test would be considered to be very exceptional. The problem is, or an issue, let me put it that way, is the majority of cases that you're going to detect are false negatives. So the biggest number of cases are going to be in cell D. I want to talk to you about yield now. And yield is a farm concept, really. If any of you are farmers or have had experience, you want to know with a crop of corn, for example, how many ears of corn that you're going to get from your crop. And we are a land grant institution, Purdue is, which means that our primary original charter, and still is today, is to help the farmer produce as much of a crop as he can with the least amount of land. So his productivity or yield per acre would be high or would increase. Well, if you take away, because we're interested in this ear of corn, if you take away all the dirt, debris, and the stalk, that really talks about what you're interested in. Again, the ear of corn. And I'm going to show you how we're going to calculate it, and then I'm going to show you an example so you can plug this information in. So yield, being the ear of corn, is really cell A and true positives. So in this particular case, in this last problem, we had 80 true positives, and the total, so that would be A over A plus B plus C plus D times 100%, and in this case our total was 1,000, and you can see that in the previous 2x2 contingency table. And so the yield was 8%. So 8% of the total cases, or 8% out of 1,000 cases, were true positives and were productive ears of corn. So that's the way we look at it, and I'll go through this again and show it to you in a little different way. Now, accuracy is a different term, and oftentimes people get this confused when they're thinking about what else we're supposed to get. But the other philosophical element is that we're supposed to, the most of the cases are to go, or all of the cases, not most, all of the cases are to go into cell A and cell D. That means we would have no error in terms of false positives or false negatives. So if we apply the term accuracy, it says what percent of the cases are classified in cells A and D out of the total number of cases. Well, as you'll recall, and here you can see the formula for it, and and you can translate it into letters, because I'm using what the cells are called, like true positive and true negative and total sample. But if you look at the example, the previous example, and you can go back and do it, that 80% of the cases, as we just talked about previously, were true positives, and 800 were true negatives. That's cell D, times 1,000 times 100%. So 88% were correctly identified as being either true positives or true negatives. So if the test is designed to separate disease from non-disease, then it does it about 9 out of 10 times. 9 out of every 10 cases. I'm just saying it did or differently. That's 88%, obviously. Now, what percentage were incorrectly identified? Well, we're subtracting 100% from 88, which would give us 12. So 12% of the cases are false positives or false negatives. So depending on the testing procedure, we could test again and identify the false positives and the false negatives. Let me ask you which would be most important in a disease situation, especially if you have a very contagious, lethal disease. What would you want the fewest of? Would you want the fewest of false positives? Those people who test positive but don't have the disease? Or do you want those people who test negative and really have the disease, those located in cell C? I think the answer that you would overwhelmingly state to me, well, I want to find those people who have the disease but don't show up according to the detection method or the screening test method, because those are the individuals that are going to be contagious and make other people sick, and they could be like Typhoid Mary and be carriers as well. So they would be asymptomatic but would be an agent for illness. And of course we would be the host. Now, this particular task I would like you to assign as for homework. I'd like you to do the following. Someplace you could print this out, or however you want to do it. I want you to go through and first write out in small, probably you won't have enough room, so you'll need to write small, what SE stands for, and then what the formula is. And then after you have the formula, what numbers do you substitute in? And then tell me whether it's column or row work or diagonal work. And then give me a conclusion in terms of what your answer means. Okay? So if you have trouble remembering what I just said, you can play it back, but it's very important that you understand it. Now, these are all the statistics that we have computed for a screening test, every one of them. Okay? So you see there's 1, 2, 3, 4, 5, 6, 7, 8, 9. Now, oftentimes you will not see this number of ways to review the data of a screening test, but this gives you a comprehensive view of the data that you have collected, and you can draw conclusions that others may not be able to. So it's not a graded assignment, it's just something, and when I say that people say, well, oh gosh, then I don't have to do it. I think that would really be a mistake, because you're going to have to know how to do these things, do these calculations and draw conclusions, etc. on the test, and the test is going to be a timed test, so you'll want to commit some of this to memory and be efficient at it. That's, I think, the best way to say it. Now, here's another important skill that you're going to have to know, and I don't think you'll find it difficult. And we'll use the not the practice problem homework, but the contingency table before that on sensitivity and specificity testing. So we will use those numbers to go ahead and solve for it. Now, in order to fill in these boxes with the information provided above, sensitivity is 80%, specificity is 90%, prevalence 10%, total population is 1,000, and PPV equals positive predictive value equals 47.1%. Now notice what I've done. I have carefully laid out and labeled my table. So under true status, I have diseased and non-diseased and total. And how you lay out your table really shows your degree and level of understanding of a screening test. And again, this is the gold standard, the very expensive method of identifying, could be screening or identifying a particular disease that would help us come to a diagnosis. Now, this is the screening test results, remember? And we're doing row work, and we're doing, I said row work, and I meant column work and row work, okay? Now, in order to begin to complete this table, we know that we have 1,000 cases. So the total population, 1,000, would appear here. Okay, now we want to know what the prevalence is, which has to do with the total number of people who are diseased that are positive, true positives, and false negatives. Okay, and that's these people. These people are really diseased, even though this cell doesn't show up in terms of diseased people. Okay, so we're going to take 1,000 and we're going to multiply that 1,000 times 10%. And you can take a moment and do that as I'm talking. And then what we're going to do is we're going to put the 100 right in A plus C. So now we have A plus C, we have the total population of 1,000 here, and we want to solve for what's going to go into the B plus D column. Okay, that's done by subtracting 100 from 1,000, right? We're going to subtract 100 from 1,000, and that's going to be 900. So our totals are 100, 900, and 1,000. Okay. Now, it provides the sensitivity and the specificity, and usually we solve for sensitivity first. So we take the sensitivity, the total number of cases that are positive, are diseased and positive, and that's both of these, and we multiply that by 0.8. So 0.8 equals 80, and so 80 cases would go in cell A. Then we're going to subtract cell A from the total, which is going to give us 20. So this is going to be 80 and 20, which is going to lead to 100. Now, when we solve for specificity, we want to take the 900 and we want to multiply that value by 0.9. So when we multiply 0.9 by 900, then we come up with 810. Now, does 810 go into cell B or does it go into cell D? Well, we're looking at the false negatives, so it's going to go into cell D, so 810 would go here. And then what you do is you subtract the false negatives from the total, and you would come up with 90, which would go into cell B. And so you've been able to complete this entire table just by having some of the information. So I'm going through this, you can see, and where the information is going. And you can see it on your printout, so you won't be confused in how we came up with each one of the answers and how they were plugged in a systematic fashion and way and our ability to complete the table. Now, let me put in the last value. Now, if you wanted to, you could do positive predictive value, you could do negative predictive value, you could do yield, and you could do accuracy to complete the statistics. We haven't done that, but it would be easy to do, and you saw me do it before, right? So hopefully that process is clear, and you're going to have to know how to solve for the unknown. Now, before I go further, I want to talk about two types of repeat screening. In other words, we're going to do screening more than once. And you can do screening with the same instrument or the same test on multiple occasions, or you can use one test of lesser quality with another test of more quality. Okay, and usually why we don't use the most expensive, usually why we use the least accurate test first, because it's cheaper. And we can run more people through, and then we can retest again, and you'll see how the total population begins to decline quite rapidly. Okay? So what I'm going to do next is I'm going to show you an example of repeat screening with the same test. I'm going to use the values presented on this slide, and then we're going to fill in the slide below, and I'm going to show you how to do that. Now, I want to emphasize that prevalence up here, and I hope you can see it, is always the number of diseased people, whether they were positive when they tested or whether they tested negative but were really positive as a result of the test, which gives us the total number. Now, what happens if we want to use this test again? Well, what that means is we're going to look at incidence. We're probably not going to test it on the next day. We may wait some time. So incidence is the number of new cases that develop over a specified period of time. And we usually have annual incidence, but this case it could be 2 weeks, 4 weeks, a month. We talked about that before. The time frame, if it's not specified, is annual, but you can use it for shorter periods.